I am motivated and I deeply believe that the path to healthcare delivery reform will run through better public-private collaboration. And I do a lot of that as a volunteer wherever I can. If there's good energy to bring stakeholders together, I'm going to join the team and see if we can make progress. In our healthcare industry today, every fragmented part of the healthcare chain has a proprietary representation of a patient's data model. And we allowed that by regulation to remain proprietary. So my doctor, primary care, has a version. If I see a specialist or many specialists, each of them have a version. If I go to the imaging center, they have a version. If I go to the pharmacy, they have a version. If I'm insured by payer A and then payer B, each of them have a separate version. So everyone has a fragmented view of my health status, subject to the role they play in our complicated weave of healthcare. You pay doctors more if their patients get healthier and have lower total cost. And you equip consumers with the resources that are needed to understand the risks and opportunities. So we're close. We've done the value-based care journey. We've been empowering people with Blue Button. Those two worlds, the Blue Button app world and the value-based care enablement world, today are not one. But if I do my job at Arcadia well, I hope to bring that world to life.
Hello, everyone. Welcome to Realign Healthcare. We have a great guest with us today, Anish Chopra. Anish, welcome.
Thanks for having me, my friend. I'm great. So excited to reconnect with you.
Good. What you been up to? It seems that a lot of activity been going on. So what's been occupying your time so far?
Well, on a professional level, I kind of divide my life in two. I've got the work I've been doing at Care Journey for almost a decade. And we've been lucky enough to merge with very dear friends of ours at Arcadia to form one, now Care Journey by Arcadia, combined organization, really to scale value-based care and to make sure all of that data infrastructure is put to its highest and best use. So that's fun. And I think more along the lines of what we're going to spend some time on today, I'm doubling down on all the public-private partnerships we can do to accelerate open APIs, open data sets. I am motivated and I deeply believe that the path to healthcare delivery reform will run through better public-private collaboration. And I do a lot of that as a volunteer, wherever I can. If there's good energy to bring stakeholders together, I'm going to join the team and see if we can make progress.
That's amazing. And for the listeners who were not following your career so far, you've been our first CTO of United States.
Yes.
So how does things like that even happen? Because that's been not a position before. So what's kind of career you require to one day say, you know what, let me just become first CTO?
Yeah, great question. My road to CTO ran through the Commonwealth of Virginia. I served as Virginia's Secretary of Technology. I was the fourth. And this is the first state in the country to create a cabinet position focused on how technology could advance the mission objectives of the state. And so maybe it's worth a minute about what that role was, because it was kind of like the minor leagues to the role that I had, which is the major leagues. So when the initial governor, Gilmore, Republican governor, created the role of Secretary of Technology, he fused three roles into one. The first was a technology-based economic development role. Marketing. We wanted companies to grow. This is the dot-com era, and there was a flag planted that said Virginia wanted to be the Silicon Valley of the East. I think we had all kinds of taglines from Main Street to East Street or something. And the message was grow startups in the tech economy here. And so the Secretary of Technology was in many ways the face of that commitment that Virginia welcomed the future leaders of the, call it the internet economy. Second, we have a lot of spend on government IT. The federal level, it's north of $100 billion. In state, it was probably $300-400 million. And it was not, let's just say, optimized. We probably didn't invest enough on security. We probably overinvested on some legacy technologies. We didn't modernize the application stack. Data was all fragmented, siloed, underutilized. So there was an idea that we could create like a CIO function that reported into the cabinet that helped to fix the systems. And there was this amorphous idea that we should have signature initiatives on where we can transform government, maybe in health and energy and education, depends on the priorities, but to do something about the applications of technology in service of a broader mission. That, like Goldilocks, the initial CTO or the secretary was a little bit more on the economic development side. So let's call that, not too hot, meaning it didn't quite, all heavily influenced in one area. The second and third were really focused on the internal operations, modernization. Maybe that's not too cold. And I was able to serve Governor Kane with this compromise, which is, continue to do economic development, support the internal migration, but really understand how does the president, or in this case, the governor's goals on transportation, the environment, healthcare, and education get transformed through technology. So my title was Secretary of Technology, but the governor called me Chief Collaboration Officer. And the spirit was hug my friends in the cabinet who were experts in their field and to serve as that voice on where technology, data, and innovation can be used to help them. Obviously, electronic health records were a big priority of mine in Virginia. And when President Obama ran as a candidate, he said, I want to bring a person to take that same capability into the White House. I was on the transition team to help draft the job description. And it looks like they went around, I'm assuming, interviewing a bunch of Silicon Valley luminaries and came to the conclusion this was less a technology engineering job and more of a policy evangelist job. And so in that case, I was lucky enough to have that first chance to serve.
That's great. And so that certainly was a fundamental change in the way we deliver care and actually look at technology. So now we are in 2024 with everything you know right now about the data standards, across the fire, blue button. What you wish you knew back then?
Well, let me start with what I want. What I want is a healthcare delivery system that is tuned to outcomes that we know in research demonstrate more, better health outcomes at lower cost, meaning the spirit of our American research enterprise. If you've got diabetes and you actively monitor your A1C, we can titrate your meds and your lifestyle to keep you from having further downstream admissions or other underlying health issues. This vision of being able to incentivize doctors, hospitals, stakeholders to build support tools along the way to help people make those decisions, I absolutely want that to be ubiquitous. And I think the fastest path to getting there remains, if I knew then what I know now, really driving consumer access and use. We sort of started down the road on the supply side, regulating the people that hold data, that they had to make it available to consumers. I probably would flip a little bit to also push for the use cases on what are the innovative applications that could help patients, doctors, caregivers, support them in putting the information to work, in identifying whether they're on track or off track to evidence-based medicine. So I'd probably tilt a bit of the blue button evangelism from release the data to tell me all the creative applications of what you would do with the data, and really emphasize that on the bully pulpit of the government.
It's an interesting point because very often as a clinician, you tell your patient your data is available through multiple ways, and people, unless they're planning to talk to another clinician or actually just travel, they don't really need a lot of that. And so overall, what we're dealing with right now is like overall digital literacy across what's available, what I can do, how I can learn, how I can better engage is pretty low. What you're saying is resonate very well, because it would be extremely helpful as a part of our access to data, actually have significant amount of resources been allocated in helping us to actually properly educate around the digital literacy, as well as teach people to use those.
So let's we have time together, so we don't have to rush this conversation. So maybe let's just play a little bit of history. You asked me, what would I do differently? So let's go back in time. President Obama is elected, announces the HITECH Act as part of the Recovery Act. We have a small band of brothers and sisters who kind of come into the administration. I was with Farzad, Todd Park, my then deputy, Danny Weitzner. We wrote a transition memo on what we were wishing Dr. David Blumenthal would do as ONC director. And the memo largely went at what I've just said, focus on outcomes, and then let the technology work in service of the outcome. So the outcome we identified in that transition memo was what eventually became the Million Hearts campaign. So let's just play the story back nice and slowly so we can kind of have a conversation about it. The lowest hanging fruit from a public health perspective is that patients that have uncontrolled hypertension, if actively monitored, could avoid unnecessary hospitalizations and heart attacks with slight adjustments to their medications regimen, counseling around smoking cessation, tackling some of the aspirin, so managing blood pressure, taking your aspirin, managing your cholesterol, and then obviously smoking cessation. So they call that the ABCs, right? We are at 25% of the population in optimally controlled diabetes. If that number may be a little bit low, but it was not where it needed to be. And so the estimate was 1 million heart attacks we could prevent if we could have a campaign of coordinated care. Now, where does interoperability and Blue Button and everything fit in? I remember vividly visiting the DC VA, and they showed me a chart up and to the right, which is the percentage of patients who are hypertensive that have blood pressure controlled. And it was like from the 20s to the 70s or 80s, going by roughly speaking. And so obviously you're like, well, what led to that? That sounds good. You went from here to here. What did you do? They're like, electronic medical records. I said, okay, say more. We're all in. What do you mean? I said, well, we mandated that anywhere in the VA that you get care, you absolutely must have your blood pressure tracked, and we're going to monitor and manage it. Doesn't matter, like a no wrong door kind of a situation. So that meant the following. If you're coming in for a mental health visit, and that was the scenario in question, it wasn't the job of the psychiatrist or the psychologist to take your blood pressure, but they built this protocol. And a lot more people had elevated blood pressure than primary care was aware of. So they had a program that would say, okay, if you're coming in and we check your blood pressure, we hit it against your historical measures, a decision support alert would say, give them this referral and have them walk down the hallway. We're going to see them in primary care. And so a lot of touch points outside of the primary care visit brought in a signal that was relevant. The patient wasn't sick enough that they were like calling the doctor to come in, but they were clearly showing signs of deterioration. That's exactly where we have chronic care management issues, right? Like only we could outreach at that time. So we made it an interoperability rule. You got to collect blood pressure as part of the minimum data set, and you got to share it, right? Meaningful use. Stage 1, we made that. At the time, there wasn't really an application layer that was building that longitudinal repository. In the VA, it's one integrated system like Kaiser. The fragmentation of American healthcare would be, hey, if I'm going to see a counselor, that counselor has no relationship to my PCP. And so that data is not connecting, right?
Before we speak further, maybe let's remind the listener what year it is and what's the state of mobile and other technology.
Right.
Because
this is 2009.
2009, iPhone just being released
Early
not
days.
so long ago. People not yet familiar with smartphones. You don't really have an app for everything. So it's a very different time for all of the listeners who did not have a chance to actively experience that period of time.
So I'm kind of giving you a longer story, but it's useful to sort of now play back in hindsight. So since meaningful use stage 1, which is the rules got finalized, call it end of 2009, we started shipping software in 2010. One could have built an application that would monitor your blood pressure across any of the fragmented systems. But we didn't really have the interoperability or the culture that was asking, and no one was really asking for it. So that meant we didn't really take advantage of this. Today, my mom and dad are, touch wood, healthy, but have, like anyone elder, they have their health issues. Mom has a challenge with her blood pressure. So she actively records it. She takes it at home, stores it on our Apple Health, invites her primary care doctors and other care team members in, shares it with me. Today doesn't have a quarterback. You would think her primary care doctor is the quarterback, but not really. She might have these other issues. So everyone's got their health issues. But Zach Kohane at Harvard, father of the Smart on Fire protocol with Ken Mandel, he did a research study called People-Powered Medicine. Permission me access to your Apple Health, and I will look at your 10-year risk of a heart attack, and I'll give you advice, AI-powered advice, on what the evidence-based protocols are, so you could sort of build a care plan, and you can work towards that. That's going to be amazing. Now, that's not a commercial product. That's like an academic study. But it tells me that we're close. And this AI era will shift the power from regulating the supply side to inspiring us with applications on the demand side that will hopefully be that virtuous cycle that will put us in a much better place to see the future we wished we had a decade ago.
So your hopes that by very fast adoption or maybe relatively fast adoption of AI-driven technology on the consumer sides that potentially may help users who may not be as technical to do it themselves to start actively demanding in usage. So something that's not just the data, but actually provide you a very tangible value as a patient. You understand your risks. You understand what to do next. You're hopefully getting more information that your physician can provide. And that will spur additional interoperability and through the Apple Health or maybe other formats.
Well, and if I go even further, there may be a future dream where that's entirely controlled by me, the loved one caring for my mom. But pragmatically, I want my mom's primary care doctor to add this as a service to her practice. And then have confidence that the doctor will add this quarterback care team collaborator function into the mix. And so that is the area where that's the closed circle. So you change the way we pay for care. You pay doctors more if their patients get healthier and have lower total cost. And you equip consumers with the resources that are needed to understand the risks and opportunities. So we're close. We've done the value-based care journey. We've been empowering people with Blue Button. Those two worlds, the Blue Button app world and the value-based care enablement world, today are not one. But if I do my job at Arcadia well, I hope to bring that world to life.
Let's follow a little bit this journey, especially from economic perspective. So you're saying let's give more to clinician. I assume for many clinicians that's mean to the healthcare system managing it, because very rarely, unfortunately, it's an individualized physician, more physician groups. So we increase payment for value-based care, for the episodic care we're currently providing. And then who is selecting application? Because for many years, it's always been a question. As a patient, I may want to use application ABCD, but this application not supported or not the one recommended by my clinician. So clinician have a BCDX application. So, and it's always some kind of a conflict. So how does it work? How do you think it should work?
Well, the good news is the digital service, the noun, the application layer, is moving from a noun to a verb. I wrote a piece on digital services shortly after leaving the government that really called this idea of wholesale digital services from retail, precisely so we don't find ourselves in this disconnect. Theoretically, if we had APIs at the center of this healthcare ecosystem, every stakeholder could connect into the network through an application of their choice. So my primary care doctor could use an app of her choice. It may be her EHR app. It could be a third-party app that natively integrates with the EHR. God bless America. My mom and dad could access it through an app that they trust. The health plan may be in the same boat. At the moment, the healthcare sector couples the data layer and the application layer. So if we want to connect, you kind of have to be into my application ecosystem. Interoperability is like this dream, this white whale that everybody's individual apps will natively share amongst each other. It's a nouns world where I have my app, you have your app, and the health plan has its app, and that somebody will move the data around safely and securely. That's a worldview. My worldview is that we have this thing called the internet. And in the internet, information flows. Unlike the current internet, we need a healthcare internet that's privacy protected, but built on the same principles of the internet. And in that case, the app is not a full stack technology platform, but it basically is permissioned to access my longitudinal record so that my record is kind of complete and available in any, my doctor can choose an app to connect to it. I can choose an app to connect to it. My health plan can choose an app to connect to it, and we can all coordinate off of the same base internet layer. That is technically what we've built from a regulatory standpoint. We just haven't built the cultural and workflow systems that shift from my stack versus yours with sharing to both of us can have any stack we want connected to the same internet. That may be the hardest hill to climb in this journey, but I'm committed to climbing that hill, and we'll get there together.
And as almost every CIO, CISO of a healthcare system or plan will tell you, the whole fact that we can connect or allow the application to connect because they comply with some of the standard doesn't really mean we have to or should allow this. And
that's right.
And that was a famous argument from Epic in Wisconsin when they were pushing against the ONC rules regarding to the FHIR API accessibility, where we don't really know where the information will go. And our duty to our patients and healthcare system to actually ensure that bad players who technically can, by standards, get access, non-controlled entities or entity that's not actually going under the HIPAA regulation, cannot necessarily connect and pull the data. So question to you, as a EHR vendor or frankly cloud provider or even healthcare system, is it your role to decide what application your patient can connect, or your role is just ensure that there is a connection pipeline that they can use reliably and according to a standard?
Well, you're answering the question without really asking a question. The answer is obviously the latter. Culturally, that's not how the world works, but that is legally and technically the way it's supposed to be.
To be honest,
the owner, whether it's the health plan or the provider, simply has to create a pipe and doesn't really have a say in how someone. Let me preface this carefully. We have 3 pipes. We have 3 regulated pipes to an open data set. So let's just play the scenario. In our healthcare industry today, every fragmented part of the healthcare chain has a proprietary representation of a patient's data model. And we allowed that by regulation to remain proprietary. So my doctor, primary care, has a version. If I see a specialist or many specialists, each of them have a version. If I go to the imaging center, they have a version. If I go to the pharmacy, they have a version. If I'm insured by payer A and then payer B, each of them have a separate version. So everyone has a fragmented view of my health status, subject to the role they play in our complicated weave of healthcare. Good. Regulations now say fairly ubiquitously that the stakeholders with data have to map that data into a FHIR open format available through an internet-based pipe, API, that has the following 3 connections. 1, it must support a consumer access. So if my mom says, I want to connect to that endpoint, technically, you don't have a choice. Doctor, health plan, whomever, you must allow that connection. We're not there yet. We're 60% of the way there. Government-sponsored plans, ACA plans, individual doctors. So we're kind of, we've crossed over from minority to majority of the American people could pool their payer data, the provider data. The second pipe is the person who has purchased the technology should have the right to field apps from an app store to be their gateway. So I have an EHR. I want to interact with my EHR through an API-powered third party that is kind of a much more optimized productivity engine. At a minimum, should be able to read the information out of the EHR, give me better support, and then I may have to copy, paste, Control-C, Control-V to write back into the EHR. But that's the second pipe, the all-you-can-eat buffet internal productivity app store for the stakeholder who has access to that data set. And then the most controversial, where you and I have spent time more recently, I also need to have a pipe that allows me to filter to a partner a subset of that data. And that could be a health plan that wants to see a roster of their patients. It could be a clinical registry like the Million Hearts Registry for patients that are at risk, have a greater than 30% risk of a heart attack in 10 years. Put them on a registry, actively monitor them, and make sure that that's known to anybody that touches them. Those are the kind of things that we have the legal structure and the technical foundation to execute. We lack the application layer that can be available to take advantage of these pipes in a manner that deliver value to a stakeholder. So we've got a little bit of a gap in the market, which is why I said to you, if I look backwards on time, I might have spent a bit more time juicing up the use cases as much as I was on helping to drive the release of the data on the front end.
So you mentioned that we will lack the application layer. And certainly we went through the several apps revolutions, and then now we're going through this incredible revolution in generative AI. And all of those require data. Not necessarily from a training perspective, but even from interaction perspective and helping you to understand your data better. So certainly we're lacking application, not because we're lacking a pool of people who desire to build application. Where do you think is the barrier? Like, why are we lacking application? If we have multiple AMCs, we have a lot of the grant funding that's being distributed over the last several decades and develop application that can help you predict scores and do a lot of other consumer level technology. Why are we still in this state?
Yeah. If I knew the answer to that question, I would be, in a different hat at a different time for a different purpose. The irony is we have exceptional academic literature. If I took 5 years of papers and had the papers converted into if-then logic or an AI-powered engine, and I had my mom's clinical data and claims history join, it would not be that difficult. And I think definitely in this AI era, it will not be that difficult to give my mom a second opinion on what the evidence-based medicine literature says should be done to make sure patients like her get the care she deserves. I'm an angel investor in a firm that has been forecasting disease progression, and Ricky Sahu is the CEO. It's Gen Health, and he walked into my office one day and said, "Look, I'm senior citizen females that take this medication, a medication my mom was on, have a higher probability of this outcome, this adverse event, which my mom had. And had I known when she was prescribed that medication that this was a probable trajectory based on real world evidence, I don't think her primary care doctor knew the linkage." And so my view is that intellectual property layer is growing and accessible. So let's just say that, like, fuel for an app would be the logic. A representation of my mom's health status in the FHIR format, as I said earlier, it takes work on our part to piece them together, but it is it is working. I keep teasing my friend Ricky at Apple. My mom has Blue Button CMS claims history downloaded in an app. She's got her Apple Health data in an app. And at the moment, those two are not technically combined. But you could envision that that'll be like imminently fixed. So we'll have the data aggregation capability. We'll have the analytic library capability. And what's missing is the entrepreneur that comes up with a method by which you connect these two worlds and personalize it to my mom. How much would I pay for that service? How much would my health plan pay for that service? How much would my primary care doctor charge for that service or offer that service? These are the questions that were remaining with the economic model for GPS routing our health journey. And I am convinced there's a there. As we commoditize the difficulty of the learning health system in code and the aggregation of the record, those two things will be lower cost, which means you could spend more money on the connectivity tissue.
I think you're spot on about the economic questions, because being in the industry for a decade, I've seen a lot of the great applications that try to predict your score or provide you a recommendation, do a lot of that. And the challenge always being is, if it's a research application, the grants money ultimately runs out. There is no one to support. But then the wider adoption is always struggle, because onboarding the patient in a system and helping them to continuously extract the value is one thing. But then creating an economic incentive for someone in the equation to pay. And very often is not a patient, because patient not currently in a mindset of paying for an individual set of advice. They may pay for services enabled by application, but not necessary for individual part. And then clinicians or healthcare system, they were looking on a very different level. Specifically, if you provide very small part of advice, like a small piece of clinical decision support, unless it's a full calculator or clinical decision support platform, they were never as hot on buying one use case specific application. So going back to things you said before, because it stuck with me a little bit about the value-based creation and distribution of the funds. Do you think there is an opportunity potentially to actually go a step further and maybe create some of those share incentives that we can distribute between digital tools developers that not necessarily guarded only by our traditional healthcare system, but kind of almost giving them slice of a pie as long as they deliver on certain outcomes.
And we know how to run the math on that. That is the heart and soul of the value-based care economic model, that there are financial actuarial forecasts for what the expected costs will be. We can monitor the actual costs, adjust them so there's apples to apples. And if there's a gap, then you can reward individual doctors or pools of doctors that come together that can demonstrate they've found a way to achieve better quality at lower cost. And that actually is working today. It just hasn't really scaled. We haven't reached the tipping point where it's going to default to be 100%. It's kind of hovering at that 35 to 40% rate, kind of.
To be honest, I understand that part, but the crazy part of this idea was you still have a gatekeeper in a clinician or clinical service around that. But now if we're trying to flip the script, because not every physician is proactively enabled to find the best and greatest of a digital technology that can predict your stuff. So if you truly want to do a lot of that, maybe there is a mechanism where you as a consumer potentially changes the equation somehow and driving additional application, frankly, creating economic incentives for those publishers that may then push some of your primary care physician.
You are, it's really funny that you're talking about this. You are on the cusp of the single biggest policy change, which is the great decoupling. And we're recording this, early October. And just this past week in Health Affairs, CMMI, Liz Fowler, Purva, there's a set of individuals that have been publishing, how do we get to 100% or universal value-based care? And a doctor that opts into a risk model that pays them more, we've been growing that, but that has not grown to the point where it's going to be ubiquitous. It's kind of, maybe it's reached some asymptotic maximum. We don't know, but let's assume it gets closer to that. Then what we're left with is some kind of consumer engaged, fee-for-service, billing code managed. So think about this. There's a new code, the Advanced Primary Care Management Code. It's a bundled code, and it is a monthly fee. The insurance companies will pay the doctor to manage someone who's at a higher risk. More money for the higher the risk, and has some measurement of outcomes. That program, you can see a future. My mom says to her current doctor, I want to work in that way with you. I want you to be I've got my Netflix subscription to you as my primary care doctor, funded by this particular thing. This is exactly the area where I think the future may ultimately sit. I call that the health information fiduciary, but it really speaks to this, whether it's the patient opting in, hey, I would like to be a part of this. In the extreme, it's the patient telling the doctor, I want you to offer this service. Then if the doctor offers a service, I want to opt in to get it. That in many ways, that could be, if you ask me what would scale, it could be the consumer demand for having their doctor incorporate this feature in their practice. That may, just like cancer navigation, cancer centers now have a navigator that can guide consumers through the journey. Most of them have been done without any revenue, like they just do it as a cost of doing business in cancer. But then CMS created a formalized billing code. So now, if you're not the MD Andersons of the world or Memorial Sloan Ketterings, community oncologists can now put that same VIP service funded off of these billing codes. So it could be a fee-for-service data sharing model, might get me to good enough outcomes than if I had a doctor taking a full, huge financial risk on my care journey.
I certainly like this particular type of a future, and that will give us way more flexibility around what we demand for.
Yes.
The interesting question here would be, I would demand a service, any kind of my high risk monitoring, maybe remote therapeutic monitoring, because we're constantly
Yes.
getting additional coding around that. But then my clinician will still do the binary exercise saying, oh, you want remote therapeutic monitoring? Here is the vendor or EHR vendor or anything to provide this, and take it or leave it, right? Like, I still do not encourage a lot of the competition on between the services, 10 different vendors around it, because they're selected it for different reasons. So do you think in the system, potentially, there is something that allow people to vote with their feet on the best technology?
Look at this. The continuous glucose monitoring device is the closest thing to consumer demand signal as we've seen in the wonky parts of healthcare monitoring. The pricing has just come out, $50, $75, I think it is, for a couple weeks, maybe 3 weeks of monitoring. Imagine a future where I can do the monitoring direct to consumer, pay for the device, but I can share back with my doctor the results in such a manner that would allow them to bill the remote monitoring, but not having to pay me for the equipment. You could start to see a very interesting dynamic where we can decouple the noun. The doctor has to send me the blood pressure cuff, right? And it's a whole vendor product, to a verb, which is, hey, either we supply you this device or you get it on your own. We don't care. There's no markup here. Just make sure that allows me to see the results. So, Johanni, let me ask you a question. Who's working on the data model for how the CGMs communicate to doctors? Is it in USCDI?
No.
So now you're getting to the next step of this conversation. Maybe we could lobby ONC or ASTP and say, hey, add this. And maybe it's like one of 100 things they have to get working on. But let's say instead we get Yale, UC Davis, Rush, Tufts. It's the usual suspects, Emory. And say, no, what if we just together said we're going to make this happen? We could run faster together than government regulation and really get at how the CGM vendors can convert their current proprietary data into FHIR, and how that can be made accessible through a FHIR server. And then, just like I said, in the healthcare internet, consumers can get a copy, their doctors can get a copy, and trusted partners like health plans can get a copy. It's all possible. It's all right here for the taking.
It's a very interesting question, Anish, only because I see easily how the very active work group in HL7 FHIR can quickly bring this information in a way that's available as implementation guidelines for people to bring it. What's going to happen next? Unfortunately, a lot of our data partners, specifically in HR, will say, you know what, we're going to do it, but we will do it in the next 3, 4, 5 years, whatever the release schedule. And by the time it's there, if it's required, we certainly do it. If not, then it's may move around. So,
well, but you're kind of, you went down the two extremes. You went down the Mother May I road. When is it scaled in the EHR? Does it have to be scaled in the EHR?
That's a great question. My opinion, the more we decouple it from EHR and allow people to bring it faster into the clinical records, if they want by any kind of the engines, the better it is. That's just not the reality of the world in 2024 right now.
Well, you say that, but in reality, it actually is. You haven't been thinking about it that way. So let me ask you this question. Would a health plan have interest in that data in FHIR format?
The plan will be interested in this data, period. In what format, I don't think they truly care.
Well, it matters because without a regulatory model, without an open data model, remember I told you, even, I don't know these companies, but let's just say Dexcom and Abbott They have a proprietary way of representing your CGM data. What obligations do they have to make it an open source model?
Right now, they don't have any obligations, but I think that would be a very nice addition. I actually never thought about this,
But
but
hear
that
me
would
out.
be very nice.
Hear me out. At this moment, do they really care to keep that proprietary?
No, because they care about adoption. They actually want you to
Exactly.
have it everywhere.
So now the question is, if they're willing to do it, who's going to convene them to work on a common data model? And if so, what other data model but FHIR would you have them converge upon?
I see where you're going.
It's not
Um,
complicated. You and I could do this. We could pick up the phone. We can call CIO friends of ours. We can call health plan friends of ours. We can call a few of again, I don't know these people from hole in the wall. We can call Dexcom and Abbott and say, hey, let's get a coalition together. And oh, by the way, what is the NCQA quality measure for monitoring patients that have, diabetes at risk of admissions to hospitals because of horrible diets and everything else? I bet you we could come up with an outcomes measure that says if you're monitoring your CGM, you're more aware of your own, what food you eat and what the impact it has on your care. Wait for who? What vendor dependency is there for us getting that coalition together? We could literally agree to do this afternoon, and we could email our friends, and by next week have a kickoff call, and
Yeah,
maybe
you're
have a
right.
sprint ready by the fall.
You touched on a very interesting idea, to be honest.
I really do. That's my role.
And one of them is when you bring a new device to market. And right now we're talking about continuous Bluetooth monitor, but we have more and more sensors.
Or
We're
a new
dividing
cancer
all of
drug,
this.
or a new cancer drug, or a new treatment protocol. Take your pick. A new way of caring for patients. Continue.
Should it be your responsibility as a go-to-market step to actually create and facilitate the coalition that you're talking about, to come up with a proposal of a data sharing standard that's maybe potentially integrated with FHIR or any other standards that's maybe applicable to the use cases you're currently using?
Okay, but let me just be, let's take that sentence and go a little bit further, okay? So now let's say the following. If you are going to get FDA approval for a new drug, if you want a billing code for your diagnostic, if you want a new care model recognized in some way, maybe a criteria of approval is just like we have the FDA label on what your indications are for what qualifies for you to get this medication. We could almost have the same logic. If I had my mom's data that pooled her FHIR data from the EHR, FHIR data from the health plans, I had that combined data set. And I said to you, when you do your research protocol to demonstrate the effectiveness of your intervention, start with what you can do in the current FHIR data model. If your particular thing requires more granular trigger codes, then that has to be closed. That gap has to be closed, and that can be done through an open collaboration. So step one, but I want to know if my mom is eligible for that intervention. Okay, eligibility calculators run on FHIR. You can see a future where that's kind of the default. Then I want to know how I execute this. So if I'm on the drug, what are the endpoints? What are the clinical endpoints? How do we know whether it's effective? We could start to collect in a registry, for lack of a better term, a bunch of information about what happens for, I'm eligible, now I'm enrolled, now you're going to monitor me. And then I want to publish in a de-identified form to the world to say, like, did it work or did it not work? And we adjust. That's the learning health system.
I would love to see it, especially the data card. Oh,
Let's build it.
we created a new startup, Anish.
And,
Because
you jumped to the word startup. Need this be proprietary, one vendor to rule them all? Or might this be a movement and a blueprint that is open, that the FDA adopts as part of its regulatory framework, that CMS embraces as part of coverage with evidence determination, that CMMI creates a fabric to say, we want to swim in clinical protocols and we're going to facilitate the learning? Might ARPA-H underwrite the buildup of a national learning lab to see what works and what doesn't work? What academics would want to play a role in studying? It's a bigger idea. And I think now that we've gotten to the point where the supply of the data is there, the pipes are connecting, you're turning on those pipes for use cases, now may be the right appropriate time to say, let's put this infrastructure to its highest and best use. And I think something like the Learning Health System that is open could very well be the vehicle.
And I particularly like the idea of the data card that you're asking the vendor to come up with, because this is a very often ignored exercise. Right now, this is definitely a retrospective thought about, oh, by the way, if we need to check eligibility, how you're going to do it, how you create those calculators is not coming from the vendor. Reporting outcomes outside of whatever they're looking for to report from the clinical monitoring is also not being calculated. But most importantly, I think the new data point, I think that's where I'm getting particularly excited, because when you create new type of the data and you have a new signal, most of the time you do not have a good way to properly file it. And what happens, we all know what happens. You add PDF to your media section of your medical records. That's what happens. And no one wins from PDFs, and there is nothing you can truly do from the PDF.
That's not a Learning Health System path.
So coming up with the requirement from the vendor that's, if you bring a new tech, you need to come up and at least bring some of the draft options for implementation guideline of your data based on the current standard, would be a significant breath of fresh air.
Yes.
Which bring me to AI. Because a lot of things will look different with AI. And in how the world you think will look in 2030? And where do you think right now we have the major risks in the way we're currently adopting AI?
Well, there are three general risks I'm always worried about: omission, commission, and Keystone Cops. What's omission? That is, somebody could have applied a model that would have helped guide my mom to a better clinical decision, but didn't offer that decision support guidance. We missed because we didn't use it. And we didn't use it because of fear, concern, lack of understanding as to safe and secure methods of doing it. So better to not introduce something than to do something and get in trouble. So that's an error of omission. The error of commission would be the inappropriate use. So the Attorney General in Texas settled a lawsuit where a vendor, I think, told a health system or several health systems that their AI model was bulletproof and no errors, doesn't hallucinate, and maybe trusted by their buyers, but they were deceived. And so they bought something that was hallucinating and providing not great advice. So that's the commission. The the word AI gets people so energized that you could fall prey to unvetted and poorly deployed models. And then Keystone Cops is my throwaway line, which is just like, we're doing dumb stuff. We're implementing it, but we're not doing it in a thoughtful way. And we're losing trust in the process. So you saw that in the New York Times article about the inbox issue, helping clinicians reduce the time to respond or to improve the quality of the response to patients that email them. You saw in the article, UC San Diego highlighting the transparency provisions from our healthcare AI commitments community that we launched with UC San Diego a year ago, December, whereby they evaluated the risks and did the proper governance. And they said, look, sharing information, this message was automatically generated and reviewed by a clinician. That should be the default best practice. Do I need a regulation to force that? I hope not. Would I think and like everyone to do this on their own? Yes. Are they naturally doing it at the moment? Not really. So this is where I would go in terms of the opportunity, is to minimize the omission, minimize the commission, and have better governance to reduce the Keystone Cops.
That's a good approach. One thing keeps me up at night sometime when I think about all the AI tools that's hitting the market, especially from generative AI perspective, or drafting my notes or helping me with the inbox, is right now we do not have a separation system between generated notes and notes that potentially being drafted with a generative technology. Anything that's being
you're saying that the IP, the content, sits unmarked, no watermarking.
Correct. There is zero watermarking. If God forbid, 5 years from now or 2 years from now, I will find that some of my models that I deployed were adding information that my doctors will not capturing in the records. I actually have no way to go back, and which may put us in a very interesting position where we may say everything after a certain date is not helpful for training, is not trainable for analysis, and we actually cross-pollinate it across of our systems. So how do we approach this? Because a lot of our infrastructure were created for a different, simpler time when there is one main agent. Our clinical contribution is our clinicians and the clinical staff. We did not have significant contributor in AI that now potentially may add a lot of nonsense, errors, some very often good stuff into the chart that's under supervision of clinicians.
Yeah, that garbage in, garbage out is a serious problem. You're raising it in a way that's really, there are a lot of use cases. Let me try to say this in a slightly different way. In the current model, I am the consumer of my own notes as a physician, I should say, not me as a patient. How do I currently track if the interaction I had with my patient was inaccurately captured in the documentation? Say somebody wrote a piece of software with the goal of upcoding and took my words and took some liberties to document a whole bunch of diagnoses that I don't really think reflected the patient's true health position, but are available in the chart because there's an economic incentive for my employer to have that conversion. Am I responsible for tracking my own content? Do I not have that voice because it's owned by the practice and the practice thinks that they own the representation of my notes to the insurance companies? That's a complex question at a large enterprise.
In reality, it's always your license. Malpractice may be your employer, but the license is yours. So, and that's why it's such a challenging question, because right now, everything I sign with recommendation of a better documentation, I wouldn't call it upcoding, but better representation of the clinical severity of the visit. I should feel free and empowered not to accept this recommendation, but ultimately it is my note, right? So when I sign it, it is my note.
Back to this issue of AI, forget AI, so the use of AI doesn't change that fundamental property that if I sign my name on the note, I am accountable for the accuracy and its validity. What's missing maybe is a feedback loop to doctors. Let's call that the malpractice insurance or inappropriate insurance, to say, hey, here are all the patients that you've cared for. I'm going to replay it back to you to say, does this accurately reflect what you wanted to say in the official chart? Yeah. I mean, if you're playing defense, not offense with malpractice, how much would you pay to get think about in responsible AI, there's often red teaming. So it's sort of like the AI that helps to generate the productivity, pajama time savings, and everything else. And then there's a related question around a second set of eyes that says, hey, something looks out of whack. The prevalence of morbidly obese patients is 5x higher in your population than it is in any other practice in this clinic. Does that accurately reflect it, or is there a chance that it might have been a little bit imprecise in its capture?
And the biggest difference, Anish, I think in my mind, is a volume. Because as a human being, you can capture some elements, but if you need to consistently capture everything, we talk about long summaries, it's just beyond human possibility. You just cannot do it. So in this case, we may be putting our clinicians in a position of blindly signing it and saying, oh, trust us, things are good. Let's focus on, we almost at the end of our recording. Let's focus on the positive sides, because we little bit went to the scary dystopian part of it. One of the classic questions I always ask to my guests who come here is, with everything you know in your elaborate career here, if you had one thing that you could change in the way our healthcare system is being coordinated and aligned between payers, patients, clinicians, what would be one of these things be?
Well, you have to acknowledge that we live in a public-private healthcare system. It's not a public system. It's not a private system. And if you have a public-private system, then you have to have an interface between the two that works. And so I would basically say what I said earlier, but with more force. We need incentives that reward doctors that deliver better care. We need applications that can incorporate all the fragmentation of my data, run it against this ever-growing library of best practices that can inform that clinician how to be successful, and me to push in case that clinician missed something. And we need maybe a set of sub-regulatory, we need like a couple of good guys. The Hippocratic oath in the digital world, capable of kind of constantly learning, oh, we should be doing this, but not that, but not this, almost empowered to work, outside of government rulemaking, but not beholden to stakeholder interests. And so we can you can see a lot of the pieces and parts we've already been talking about, just turning the dials of strength to make them a little bit more punchy.
Thank you. And I certainly hope it will happen. Anish, thank you for joining us for Realigned Healthcare. It's been a true pleasure.
Thanks for having me, my friend.